I will just very quickly introduce Dr. Hutchins. Most of you know her already, but she is one of the pediatric hematologist oncologists at Kapiolani. We are super lucky to have her. And this is a topic that at least we have been seeing so much more of in the hospital. I don't know if that's the same for the group in the outpatient setting, but very happy to have her talking about CNS tumors today and just giving us all a refresher. And with that, I will pass it back. I will be here to help pass along questions. I'll save most of them for the end unless it's anything urgent that wants to slide in. Feel free to add anything into the chat, or you can always unmute and share your voices with us. So passing on to Dr. Hutchins. Thank you so much again for being here with us.
Thanks so much for the invitation, Dr. Luker and everyone. And yeah, thank you all for joining. I'm going to go ahead and share screen. And all righty, is that pull up for everyone, the PowerPoint? Yes, okay. So yes, thank you again. And today I'm going to focus on central nervous system malignancies. So the more aggressive forms of brain tumors. Tumors in general are more encompassing, in which I'll touch on some that are not necessarily considered malignant, but again, the focus of CNS malignancies. So I have no financial interest to disclose. And the learning objectives, thanks Summer for going through. So again, to be able to state the prevalence of CNS malignancies among children, recognize signs and symptoms of those who are presenting with a CNS tumor or malignancy, to list treatment modalities for these patients, and then to recognize late effects that are related to patients' underlying diagnoses and treatment among survivors of CNS malignancies. So I'm just going to start with some questions that'll be reviewed at the end, just kind of to think about as we're going through this. So first, central nervous system malignancies are a common cause of cancer-related death among children. True or false? Number two, which of the following may be a sign or symptom of an underlying CNS malignancy? Headache, ataxia, impaired upward gaze, or all of the above? Number three, which of the following are treatment modalities for patients with CNS malignancies? Surgery, radiation, chemotherapy, or all of the above? And number four, which of the following are potential adverse late effects related to treatment of CNS malignancies? Hypothyroidism, secondary cancers, depression, or all of the above? So I wanted to also just present a few cases. I'm just going to do like a one slide for these patients to also kind of just have these patients in your mind when we go through the rest of the PowerPoint. So the first case, this is a 2.5-year-old girl who presented with progressive ataxia for about a month, and then was noted to have difficulty with standing, and then started having some intermittent vomiting noticed the past week prior to admission. She was previously healthy, developing normally, and there was no known family history of any underlying malignancy or neurological disorder. When she presented, her vitals were stable. She was alert and interactive. She did have difficulty standing with assistance, and then had this wide-based gait with this truncal ataxia. The rest of her neuro exam was intact. An MRI brain and spine was done that noted a 3.3 by 3 by 3 centimeter round heterogeneously T2 hyperintense mass that was coming from the roof of the fourth ventricle, causing moderate hydrocephalus. Case two, this is a 12-year-old previously healthy male who presented with headaches and double vision for about 1 month. His mom and maternal grandmother were known to have a history of breast cancer. They were, of which it was BRCA negative per report. On his exam, his vitals were also stable. He was alert and otherwise well appearing, but he did have a significant upward gaze palsy with papilledema that was noted when he went to the ophthalmologist. An urgent MRI brain and spine with and without contrast was done that noticed a heterogeneously enhancing mass within the pineal region that measured, again, about 3.3 by 3-ish centimeter mass. And of note, he did have laboratory studies that were done that noted a significantly elevated beta HCG with a normal alpha fetoprotein. Case three, this is a 20-year-old male who had a history of recurrent sinus infections and intermittent asthma, who presented with progressive ataxia for the past 3 months. He was noted to recently have change in his speech and was saying the past few days was having difficulty swallowing solid foods and finding his words. He was also noted to have some increased difficulty with walking, but was walking on his own. and was noted by family to have some slurring of his, it was noted to have some blurry vision, some slurring of his speech by his family. On exam, he was, again, normal vital signs. He was alert. He did have slurred speech, but it was comprehensible. He had endorsed some blurry vision with lateral gaze bilaterally. His tongue was midline and his other cranial nerves were intact. And he had a little bit of ataxia, but was, again, able to walk unassisted. An MRI brain with and without contrast was done that noted a large 4.5 by 5 by 4 centimeter abnormal expansion with diffuse abnormal T2 signal in the parts of the midbrain, pons, brainstem, and the craniocervical junction. And case 4. So this is a 2.5-year-old female with a known history of, with known neurofibromatosis type 1, who presented with proptosis and esotropia of her left eye to her ophthalmologist. She was noted to have bilateral vision loss on ophthalmology exam, with left being significantly greater than right, was urgently started on steroids and sent for a stat MRI in the ER. Again, she was known to have NF1 and was being followed by multiple providers. And she had had a recent ophthalmology evaluation a few months prior that was normal. Interestingly, there was no known family history of NF1 or other malignancies. This little girl was also with normal vital signs and otherwise well appearing. She did have diminished pupillary reflex bilaterally. Her extraocular muscles appeared intact when she looked around, and then, but was noted to have a left esotropia and a little bit of left proptosis. Also, she had multiple hyperpigmented macules and papules to her legs and back, and then a nodular lesion adjacent to her anus. She underwent, again, a stat MRI of her brain, including the orbits that noted optic nerve gliomas involving the bilateral optic nerves with associated papilledema. And also, interestingly, she had these other multiple areas of this abnormal intensity of multiple regions that was associated with her neurofibromatosis history. So again, those are just some cases for people to kind of keep in their minds about patients, because this is why we do what we're doing. So CNS malignancies in children. So why is this important? So this is the most common solid malignancy among children. And it comes only second overall of number of most common cancers after leukemia. There's approximately 4,300 that will be diagnosed with some form of a brain tumor in the United States annually. And unfortunately, this is the most common cancer-related death among children. It used to be leukemia, but the outcomes for leukemia have become so improved over the decades, where survival rates for CNS malignancies has really been pretty stagnant, unfortunately, and so now has taken over as the #1 leading cause of death for patients with cancer. It's a very diverse group of diseases. These are classically categorized based on histology primarily, and there have been multiple revisions to the WHO classification system, most recently being in 2021, which has implemented a lot more of the cytogenetics and molecular findings of markers, which has added dozens, I think over 100 different subtypes of not only malignancies, but other tumors in general that are considered non-malignant. And there are multiple factors that are going to affect patient treatment and their prognosis, ranging from the patient's age, the diagnosis, underlying specific diagnosis of their malignancy, where is this tumor located, and the extent of their disease. So the good thing is that over 70% of children with CNS malignancies do go on to become long-term survivors, which is typically defined as 5 years from diagnosis. But this does vary widely, with some very dismal outcomes among certain subsets, such as the classic used to be called DIPG, or diffuse intrinsic pontine glioma, as one with still overall survival of approximately 11 to 12 months, with others where there are lower grade gliomas that have over 90% survival. So again, the range is broad and depends again on those numerous factors that I just mentioned. Why do these happen? Most of the time we don't know, but there are multiple genetic conditions that have been associated and are associated with the development of CNS malignancies, one of which being neurofibromatosis, but other things like Leigh-Fraumeni syndrome, tuberous sclerosis, mismatch repair defects. And this is important not only to help with understanding why this happens, but also treatment modalities can sometimes be not only targeted, but more effective in certain subgroups of patients. There are significant acute effects that are going to occur to these patients during treatment due to the treatment, which I'll get into later in the presentation, and a multitude of late effects that are common among those who do become long-term survivors. So this is just taking the major histologic subtypes just for you to see gliomas. But when you talk about gliomas, again, this is a very big umbrella term. You have low grades and high grades, and above and below those, again, you have a multitude of subtypes as well. So these are just the top major headings, of which we see patients with gliomas, choroid plexus tumors, embryonal tumors. So those are patients with medulloblastoma, ATRT, less common, much more aggressive, various pineal tumors, germ cell tumors, and sometimes you'll see metastatic disease to the CNS. So common subtypes again in pediatrics. So gliomas overall are the most common type, of which there again are low grades and high grades. Oftentimes your low grade gliomas, one being your pilocytic astrocytoma, is often considered a non-malignant tumor, where sometimes it'll actually start to shrink on its own. You can observe depending on where it is. And sometimes with resection alone, that's all you need, and patients do just fine. They do have the potential to grow back and rarely to change into a higher grade. But in general, there's oftentimes the lowest grades are considered, yes, a tumor of pediatrics, but not necessarily malignant. Whereas your high grade tumors, your grade 3s or grade 4s, previously known as things like glioblastoma, now categorized as these diffuse midline gliomas or diffuse high-grade gliomas of pediatrics. We also do see those, but unfortunately not quite as commonly. Embryonal tumors, so medulloblastoma. So this is considered to be the most common malignancy of childhood, particularly less than 14 years of age. And less commonly, although we have had a handful of patients, at least since I've been here, with atypical teratoid rhabdoid tumor. Ependymomas, often arising from the ventricle, or sometimes you can see in the around the spinal cord, and then germ cell tumors. So how do these patients present? You can imagine a wide range, right? Wide range of signs and symptoms. And this is going to be also related to many different factors. How old is your patient? If this is an infant, they can't tell you they have a headache, so they're going to potentially be more irritable. Depending on if this is a cerebellar lesion, you could have cerebellar findings where, again, if it's leading to obstructive hydrocephalus, anything leading to obstructive hydrocephalus, you could have headaches if you're able to talk, morning vomiting, etc. So again, tumor location and patient age. And it's going to be associated as well with sometimes with the type of tumor, which often coincides as to where the tumors are located. So again, this is just a list in alphabetical order, but ataxia, again, more typically with your patients with cerebellar lesions, but also again, if there is other massive factor causing hydrocephalus or midline shift, you could, or affecting a motor cortex, then you could also present with ataxia. Blurry vision, cranial nerve palsies typically are going to be in your brainstem, patients with brainstem lesions. Weaknesses, headaches, urinary incontinence, sometimes patients with spinal cord malignancies. Patients could present with symptoms of DI, with increased thirst and urination. Again, be more irritable if they're a little child, seizures, and again, vomiting. So diagnostic workup, first and foremost, as with most of our diagnoses, is taking a thorough history and doing a good physical exam. So in terms of history, how long have symptoms been ongoing, when do they occur? Again, timing can sometimes be important. Physical exam, not only a thorough neurological exam, but also skin. Again, patients with NF1, for example, or tuberous sclerosis could have different skin findings. So and then also if there's any kind of dysmorphology to suggest an underlying genetic condition. And then alongside with history would also be family history, to ask if there's any known family members with underlying brain tumors at a young age, breast cancers at a young age, leukemia at a young age. So things like Lee-Fraumeni syndrome, or colon cancer in younger patients, mismatch repair defects with things like Lynch syndrome. So again, important in everything we do, this is the same thing. And it often will start with the pediatrician or the primary care provider. So to just hone in on how important the primary care team is in these patients' diagnosis and care. Laboratory evaluation may or may not be useful. So patients who have germ cell tumors, for example, this could actually be diagnostic. So patients who have elevated beta HCG and or alpha fetoprotein could be suggestive / diagnostic of this type of tumor with imaging that shows a brain tumor. So in a rare instance, that could be a time when you actually wouldn't necessarily need a tissue biopsy. But ultimately, for most of these patients, you will need a tissue biopsy. In terms of imaging, MRI with and without contrast is our gold standard. So you want to get a good picture of the brain, and oftentimes you'll include the spine, and then again plus minus the orbit depending on the concern for where your lesion is. If you have patients who are acutely having acute findings where they're obviously their consciousness is altered, you're concerned for potential herniation or bleeding or something real acute, CT is much quicker, can be done unsedated. And so oftentimes if patients are having severe serious symptoms that can't wait, then you could start with a CT. Lumbar puncture is sometimes indicated, and again, this will depend on the patient's diagnosis. So we do this as part of staging, for example, with patients with medulloblastoma a few weeks after their surgery as adjunctive to detect for extent of disease if there is CNS spread. Although the spine is quite sensitive, about 10% of patients could be missed without diagnostic lumbar puncture. So for that purpose, and then again, going back to germ cell tumors. So this is one other indication where if it's not elevated in the serum, for example, if you don't have those markers in the serum, sometimes it can be elevated in the CSF, and that would also be diagnostic for those patients and could potentially avoid biopsy. But in general, most of the other tumors will not necessarily require. So treatment. So you'll see this a lot. That's dependent upon numerous factors, but globally, there's a lot of similar things for the majority of tumors. So one, you want to make sure you have the correct diagnosis, because a high-grade glioma versus a low-grade glioma, it's very different, as an example. Having the correct cancer stage and extent of disease. If you have an extremely poor prognosis, you might want to focus. You always want to focus on quality and supportive measures, but depending on your aggressiveness of a surgery, if you're going for cure, or if you're trying to be palliative. So the extent of disease is really important. Where is this tumor located? If you have a tumor in the pons, it used to never ever even be biopsied, but now it is becoming much more routine to at least do biopsy, but of course resection would be fatal to the patient. And then age of the patient. So radiation therapy, for example, is a mainstay of therapy for a lot of the tumors that we treat, but for little ones less than 3 years of age, for example, we try to avoid if and when we can. And this truly is a multidisciplinary disease process. So again, starting with the primary care providers, and is then going to involve a number of other specialists. So from your radiologist, neurosurgeon, and I put these down because I want everyone to know how important everyone is. And I'm sorry if I left off, but the right pathology, working with radiation oncology, and having good collaboration from medical oncologists, neuro-oncologists. We have, adolescent and young adults who kind of fall in between. So being able to work as a team, the importance of nursing, having palliative care early involved. I'm a big advocate, depending on the diagnosis and prognosis of the patient. Social work, dietary, integrative medicine, we have and are fortunate. Rehab is a huge part. A lot of our patients with medulloblastoma will sometimes go on to develop something called posterior fossa syndrome, where after surgery they have trouble with walking and talking and weakness, and it takes a really long time for them to recover. And so rehab services have been huge for that. Endocrinology, psychiatry, this is having any cancer diagnosis is a huge life-changing event. And especially again, these teens and younger kids who are growing and, going through something so different than their peers, it is really wearing on them, and then also their families. And then genetics when indicated. So primary. So in general, when you have a brain tumor in general, malignant, non-malignant, most of the time you want to take it out when you can. So surgical resection is almost always your initial treatment of choice, again, when possible. There are, again, those certain subtypes, like your germ cell tumors, where tumors could be treated, or the cancer can be treated without surgical resection, but in general, when you can take it out, most of the time you want to take it out. And then this is often going to be in conjunction with neoadjuvant, meaning before surgical resection, or adjuvant therapy, whether it's in the form of adjuvant chemotherapy or adjuvant radiation therapy or both. Going on to radiation therapy. So again, this is going to be dependent on, again, the age of the patient. So we do try to avoid when they're super young. We say less than 3, you really just don't give unless it's going to be palliative intent or there's really no other option. And even 3 to 7 is not an ideal time, but we do use it for certain types of cancer, particularly medulloblastoma. Going back to that because it's, again, the most common because it is so effective. And then the type and location of the malignancy. So some will not need radiation, some it's standard of care. High-grade glioma, patients with high-grade glioma, it's standard of care to receive radiation therapy. Medulloblastoma, if you're old enough, standard of care to receive as part of your treatment. There are different types, just like any kind of medicine and chemotherapy, there are different types. So photon and proton. So we have photon, that's much more common. There are centers all over. That is the center we have here in Hawaii. Photon therapy, and they're excellent and it's very effective. Photons, from my understanding, is the thing about photons, though, is they have what's called more scatter. So they can sometimes affect the surrounding tissue, the healthy surrounding tissue, more so than would proton therapy. Proton therapy, it's delivered more directly to the tumor without that scatter around. And so for when you have, particularly a child, if they have a good outcome prognosis and you want to try to avoid that scatter to the healthy tissue, sometimes we will refer to mainland with the collaboration of our experts here if they feel that that's also in the best interest of the child, to a center on the mainland, such as Seattle or a place in California. And there have been other techniques that have occurred through the decades to try to mitigate adverse effects that come at the cost of radiation therapy, such as decreasing dose. So can we give less dose to certain cancers? And then also where it's given. Can we reduce the range? Like, can we just focus on the tumor, or do we have to do the whole surrounding ventricle, for example, of these tumors? So these things have been studied and to try to, again, avoid the adverse effects. So chemotherapy. Is definitely utilized, also varies, again, upon the type of cancer. Our brain and our spinal cord are these important sanctuary sites, right? And so they're well protected, meaning it's hard for us to penetrate with appropriate medicines to be able to be effective. So we want to use therapy that is capable of doing that. So on these next 2 slides, I've just listed some of the agents, and I believe you guys have access to the slide deck if you want, I'm not sure. But so alkylating agents, and again, many of these are commonly used in non-CNS malignancies as well. So things like lomustine or cyclophosphamide, ifosfamide, temozolomide, old drug, oral, used in adult, can be IV, used in adults and kids with high-grade gliomas. Yes, antimetabolites, so high-dose methotrexate. We also use these in patients, for example, who have leukemia, to help treat and prevent leukemia from getting into the CNS. Etoposide, epipodaflotoxin, or a topoisomerase inhibitor. And then your platinums, back to training with cisplatin, carboplatin, and we'll get into side effects, but sometimes can affect hearing in the little ones. And then your vinca alkaloids, vincristine and vinblastine. And then more recently have been things called targeted therapies, or more directed specifically at the mutations of patients' tumors. So something called MEK inhibitors, mitogen activated protein kinase inhibitors, depending on if patients harbor certain mutations where these could or could not be effective. This has been approved for patients with NF1 who have low-grade gliomas, and is being studied in patients without NF1 as well. BRAF inhibitors, so people with BRAF mutations, and again, these are all just changes that come within the tumor. Immunotherapy has been studied more recently, and has been shown to be effective in patients, for example, who have mismatch repair defects or things like Lynch syndrome, where it's actually been shown to be effective, which is great for those patients who have that option. And then patient tumor targeted therapy. So when patients have tumor resected or take a biopsy, it's sent to the pathologist, but now it's also being sent for a plethora of genetic sequencing or next-gen sequencing. our institution, we typically send to UCSF. They have a really big panel, and they check for a lot of different mutations. And based on those results, sometimes they can suggest if a targeted therapy may or may not be useful for this patient. So what are some of the acute effects of therapy? So we see these patients, they have their diagnosis. So, what are the things we're worried about? So surgery, like any surgery, risk of bleeding, stroke, infection. And I kind of touched on that, called posterior fossa syndrome. So this is classic, again, with patients who have cerebellar masses that are removed, where they can unfortunately develop things where they are unable to speak following surgery, have loss of function or movement of their arms or legs, and sometimes will not eat as much as they were previously. Sometimes this recovers within days to weeks, and sometimes these patients go on to have long-lasting effects that can sometimes be lifelong. But they do, with rehab, we see significant improvement over time for these patients. With radiation therapy, one of the biggest things we see, they are high doses, so you can over time start to see skin breakdown, and the radiation oncology experts are very helpful with helping us to treat whenever there's any kind of wound or with topical therapy, and it does recover. And then again, damage to surrounding tissue, surrounding healthy tissue. Not typically acute, but you can over time see brain necrosis, and that has happened before, and it's really hard to differentiate that from a current tumor. So sometimes you can see that. Chemotherapy, so there's general and medication specific side effects, which I'll get into a little bit after this slide. And then immunotherapy. So with these immunotherapy, it's trying to rev up the immune system to try to fight the cancer. But with that can also come the development of autoimmune disorders such as hypothyroidism or inflammatory bowel disease or lung disorder. So being aware of this for these patients who are on these treatments. So in general, chemotherapy, it tries to kill rapidly dividing cells, which is good because it kills cancer, but it's non-specific. So it goes into your body, whether it's via the bloodstream, whether you take it by mouth, and it's going to affect all of the cells where there's essentially blood flow, right? So that could be anywhere. So your hair is rapidly growing, your GI tract is you bite your inside of your mouth, I tell patients, and it grows back really quickly after you have a sore. But unfortunately, it can lead to things like mucositis, and cause nausea, vomiting. And then your bone marrow, your cells are, rapidly growing and dividing. So this can also lead to significant cytopenias, anemia, thrombocytopenia, leukopenia, putting patients at risk and becoming immunocompromised and at risk of infections. Some more specific adverse effects that we see, we talk about frequently. One thing in terms of with vincristine or vinblastine, things like constipation, and sometimes some neuropathy, depending on how much patients get over time. Not common, but we do protect against hemorrhagic cystitis for our patients getting alkylating agents. And then going back to the cisplatin and carboplatin, which are frequently used, things like ototoxicity and nephrotoxicity. And one slide on relapse. So relapse is unfortunately real for many patients. Often you'll see it in the primary location. Sometimes you can have CNS spread, and much less commonly, although not impossible, could have systemic disease. For patients who have CNS malignancies, it's encouraged whenever possible to enroll patients in clinical trials when they're available. Just in general with pediatric cancer, decades before I started doing this, patients have been enrolled, and we're grateful for them and their families to enroll in clinical trials to try to improve not only cure rates, but also improve adverse effects, to minimize adverse effects over time, which has been one of the reasons why survival rates have improved over decades. So whenever these are available, we do highly encourage if we feel it's in the best interest of the patient. And this comes in different forms. So you can have they range from phase 1s to phase 3. So phase 3s are your most advanced trials, where sometimes you're comparing a standard of care arm to the standard of care arm plus or minus something, or decreasing something or adding something, and comparing two groups of patients to your early phase 1 trials, where they're trying to see if a drug is tolerated in a patient, because there's really no other good treatment for a patient with progressive or relapsed or refractory tumors, or tumors that don't have any known cure. And then late effects. So I'm also part of the adolescent young adult survivorship clinic, and we also in the pediatric ambulatory unit here at CAP, where we see our patients with for pediatric hematology and oncology disorders, see survivors and the patients who are off therapy. And survivors, just going back, it actually starts day one of diagnosis. So we do see all patients who have had a diagnosis as survivors. But once patients go on to be longer term survivors, there are a plethora of unfortunate adverse effects that can happen, and it's real. And we see many of these patients in our adolescent young adult survivorship clinic decades off treatment, which is wonderful to see, and with a handful of side effects that came along with what we did to try to cure them. Anywhere from cardiovascular health, endocrine, you can imagine radiation treatment to the brain. It can stunt their growth and development. Anything, if you have radiation along the brain and spinal cord, it can lead to secondary malignancies down the road. Sometimes it can be benign things like meningiomas that can be resected, to things that high-grade gliomas, sometimes incurable. Alkylating agents, although rare, have the side effect of secondary leukemia. So again, these are things we try to talk to our patients about when we diagnose, but again, when we can cure, our primary goal is going to be cure with minimizing late effects whenever possible. So these patients are an important group of patients, and they're actually thought to be considered a vulnerable population. And so we have specific survivorship care for them. And that can go, it can come in the form of many different clinic types per se. It doesn't necessarily have to be at an oncology center or with an oncology provider. Oftentimes this is done with primary care providers, but ultimately you want to make sure you're focused on the patient, the individual patient, and it's based on that person's history, not only the diagnosis, but the treatment that patient received. And the follow-up and the things to be aware of are going to be based on those treatment modalities and the things that were used for that patient, because their long-term effects could be very different from another person's long-term effect. It's a multidisciplinary, just like at time of diagnosis, approach. As an example, in our clinic, we have a nurse practitioner who does tons of education with the patient and the families. A physician, we have a social worker, a dietitian, and we stress the importance of psychological care because we know that this is such a significant adverse late effect that can happen as psychosocial disorders such as anxiety or depression or PTSD, even from having had cancer. And again, to stress, this begins at diagnosis. So although you're, thinking about the now and the cancer and treating and curing, you also want to think about, these patients want to have babies one day, or, like their growth, should they start taking hormone therapy? So you want to be thinking about things that could happen in the future, as well as the things that could happen now. We promote health and wellness, so we want to make sure these patients stay healthy. So not only are we asking about just their, survivorship focused things, but also, avoiding smoking and excessive alcohol use and unsafe sex practices, and keep them healthy. And because we know that these other adverse effects, going back to, for example, cardiovascular health, if we can keep people with a healthy weight and avoid high blood pressure and diabetes, that will help those patients, because we already know that some of them may be, for example, at risk of cardiovascular disease. And then again, screening for late effects. I talked about, this, but screening particularly for certain patients. So we are fortunate that we have something called Passport for Care. What this does is it populates, it's input by the nurse practitioner, but all the data gets input into a system, and it populates the patient's treatment summary, which is something all patients who have had cancer should be given, is a cancer treatment summary. And that also can be provided to their provider, so their primary care doctor, their eye doctor, their gynecologist, whoever it may be, so that they can see what that patient had. So that's their treatment summary. And then as part of the treatment summary, this what's called Passport for Care, it's built through the Children's Oncology Group, of which we are one. So our institution is part of something called the Children's Oncology Group, which is multi-institutional, hundreds of hospitals around the world, essentially, working together in collaboration, working through clinical trials for these patients with cancer, for the reasons I spoke about to improve survival rates and decrease side effects when can. But they've also helped to put together these long-term follow-up guidelines for us, which is super wonderful. So once we've input their data into their treatment summary, this then correlates to a specific nice little guideline for the individual patient to follow. It tells us how often do they need an echo? How often do we need to check their thyroid studies because they had radiation therapy? How often should we check their hearing screen because they received cisplatin? So it's a really nice tool that we have to use, and that also is provided to the patient and can also be provided to primary care providers and their other providers as well. These follow-up guidelines themselves are over 200 pages. And free to the public. So they're free. You can PDF them if anyone's, I think I put it at the end on one of my references, but if anyone's ever interested, you can see, and you go and you see radiation and you see the things that people are at risk for. But just to kind of throw that out there, that it does exist and we use it, and it's super helpful. So with that, I'll go back and I'll go through the questions. So first, central nervous system malignancies are a common cause of cancer-related death among children. This is true. Again, this is the most common cause of cancer-related death among children. Used to be leukemia and now has taken over as the #1 cause. Number 2, which of the following may be a sign or symptom of an underlying CNS malignancy? And this is all of the above. Again, a plethora of signs and symptoms depending on where tumors are located, age of the patient, extent of disease. Number 3, which of the following are treatment modalities for patients with CNS malignancies? Surgery, radiation, chemotherapy, and all of the above. Again, also just based on, a lot based on tumor type, patient age, extent of disease. And number 4, which of the following are potential adverse late effects related to treatment of CNS malignancies? Hypothyroidism, secondary cancer, depression, or all of the above? So all of the above. You can have endocrinopathies often associated with not just radiation, but radiation therapy. Secondary malignancies, those can come again after receiving radiation or alkylating agents or even etoposide. Depression, screening for psychosocial, screening for psychosocial distress and problems among these patients is of importance, particularly patients who have brain tumors or brain malignancies. And so then back to our case, back to our cases. So the first one, the 2.5-year-old little female who had ataxia and a mass in her 4th ventricle was ultimately diagnosed with medulloblastoma, which is considered to be a grade 4 lesion. She underwent gross total resection, and because of her age, she is undergoing intensive induction chemotherapy and will be followed by what's called autologous stem cell transplant, with the hopes to avoid radiation therapy, but potentially could be used in the future should this recur. She was non-metastatic. Case number 2, this is a 12-year-old previously healthy male who had double vision with upward gaze palsy and an elevated HCG with a pineal mass, and was diagnosed with a localized pineal germinoma. This patient actually did undergo biopsy. It was not known at the time what it was, but did undergo biopsy and received chemoradiation and has been off therapy a while. And case 3, this is a 20-year-old male who had progressive headaches with changes in his speech and difficulty swallowing, with some blurry vision endorsed with bilateral gaze, and had this extensive mass of his brainstem, and was unfortunately diagnosed with a diffuse midline glioma, previously known as DIPG. This patient did receive radiation therapy with concurrent temozolomide and went on to multiple clinical trials and did really quite amazingly for quite a while, and succumbed to his disease after a little over 2 years of treatment. In case 4, this 2.5-year-old little female with NF1 who had this esotropia in this left proptosis and change in vision, ultimately noted to have these optic nerve gliomas diagnosed with bilateral optic pathway gliomas associated with NF1. These are considered low-grade gliomas. Oftentimes you can monitor these in patients, but when it's causing significant adverse effects, such as this little girl essentially almost lost her vision in her left eye and was losing her vision in her right eye. These needed to be acted upon. And so she underwent urgent chemotherapy and is recently finished and has been improved / stable since. So those are some references for you all. And I thank you all for your time, and I'm happy to take any questions.
Thank you so much for that. And thank you also for all those cases. I always find that so helpful because they really do present in such a, broad variety of symptoms often, that it's good to kind of have those reminders of how, differently patients can present. Summer had to jump off, so we were a little bit too late in putting up the poll questions, but I'm glad you were already able to go over them. We're getting through this. It's all going to be great. I don't see any questions in the chat yet. But I guess for myself, it's so easy for me to, in the hospital, which is why I love being a hospitalist. I have everything immediately accessible to me if I have any concerns. But I guess for myself, if I were an outpatient pediatrician, if I see, any of these warning signs, it could be a CNS tumor, but there's also a high chance that it's a whole big variety of other things or absolutely nothing at all. What are and then, if you do send for workup, obviously things would take longer unless you send them, to the emergency room. But then I guess you kind of have to weigh, do you just send everyone to the emergency room that you're worried about? Or I guess, I don't know if you have any recommendations on this very difficult, broad question.
Yeah, no, that's a great question. And I feel for you guys, like I feel for the gen peds, right? Because by the time we see them, you guys have already done that workup, right? Or they're already in the ER, and so that often is, I would think, making the diagnosis is like one of the hardest things, right? Because you're right, we get them once they've had the tumor or once they've had the problem. And so, I think you're right. And common things are common, right? If you have headaches, like that's super common. And if there's family history of migraines, these things are common. I think doing a constellation, I think, just ensuring you're being thorough with everything and really getting a good timeline and trying to decipher, are these things progressing? Is there a red flag? Like you said, do these headaches seem to be when he wakes up every morning, like he's having them? It's like, oh, he comes home from school and like, he's got a headache, but like it's probably school or like the whatever, he's not eating drinks. It could be much more benign, right, if it's at that timing. So, and that's just one example, because it is hard, right? My kid's fussy and they're not wanting to eat. Like you're not going to think brain tumor in a baby who is, throwing up once in a while, right? You think reflux or something more simple. So unfortunately I don't have like a pinpoint timing, but I do think I think follow-up is important, and diaries, right? Like I always say, keep a headache diary if there's going to be patients who have headaches, like when is this occurring? Like I'm not wearing my glasses and I have blurry vision, or is your blurry vision getting worse? So I don't know if that's super helpful, but then also doing those other things, because although we say we don't know, and we don't know for most of these kids, we don't know why this happens. And, a lot of times there isn't a genetic trigger, but sometimes there is. And so sometimes, just making sure that you have asked those questions. Oh, like, yeah, his dad died at 35 of whatever, and like to really make sure that that's that is that those kind of questions are asked too. And then again, yes, neuro exam, right? Like primary care, like doing the best that you can with your the neuro exams, and just trying to be as thorough as you can too. And if you need to do a close follow-up, right, to have them back in a couple weeks or sooner rather than later, just a phone call, check in, how are things going, have things resolved, or oh no, they're getting worse, they're not getting better. But yeah, you can't go in CT or MRI every patient that comes to your clinic. So again, I feel you for that. So it's not a great answer, but I think if there's certain trigger things, and like weakness and things in legs, if there's things for like spinal or like those, some kind of things are not ever really normal, and might just indicate and I know certain, like everyone doesn't have access to MRIs, right? All, you know, depending on where people are. So it can be hard and challenging.
No, absolutely.
Yeah.
Even on the inpatient side, I feel like you sometimes see things that, you know, have been already gotten so far, and it should be so easy because so much of the workup has been done outpatient, and even there we're kind of struggling. But you brought up the, you know, potential genetic component versus not, and that actually leads over to a question that was asked, is there any commonality with lifestyle, family history, exposures, past infections, prenatal exposures, all that good stuff?
Yeah, that's good. And, you know, one of the questions we always get, thanks for the question. One of the questions we always get asked, right, is like, why did this happen? Like, was it because I was exposed to this? We drank this, like this happened. And in my understand, in like my training and like from what I'm aware of, not really. Not really. Nothing like comes to mind in terms of a specific trigger. I mean, there are lifestyle things for adults, right? You know, tobacco smoke or certain things on the job, but in terms of like kids and things and prenatally, not really that I'm aware of, to be honest. Yeah. But thank you for asking. Yeah. Family history would be, yes, you know, genetics, right? So, you know, we've seen patients with Leaf-Romani syndrome or again, Lynch syndrome. So those are associated with brain tumors, definitely, or other genetic mutations, if that answers the question. But in terms of past infections, I mean, HIV has been associated with things, but again, that's not something we commonly see. So if there was a transmitted case that went unmet, you know, like primary CNS lymphoma, exceedingly rare, like I hope to never see that, right? But it's seen in the adult side. But that's all as of now, that I could think of.
Yeah, and that this is not a CNS tumor, but that reminds me of a case of congenital AML that I encountered in my intern year, and that was really one of the big questions. Was really exactly that. Is there anything we did during the pregnancy that, you know, could have caused this? It was very interesting. There was 2 back-to-back that were born like a month apart. That year, and it's so rare, right? So
yeah, very.
Yeah, never gonna forget that one for sure.
Yes, no, like many of these patients, yeah.
Right, and I mean that's the thing. I feel like they all present ultimately so uniquely in their own way. I don't have any other questions in the chat right now. We do have a few more minutes, so I'm gonna give people a chance to add any more questions. I'm sure you can also ask Dr. Hutchins questions that aren't specifically CNS tumor related if you have any other oncology patients or questions.
Oh, sorry, yeah. Reading that chat, yeah.
Yes, I was just gonna say, yeah. And yes, it's totally right. It's not ideal, but sometimes the SAT CT can be reassuring when working up new headaches. Last sedated MRI took 8 months to get done, and I'm honestly not surprised, unfortunately, getting it approved first of all, and then going through the whole process of especially trying to get the sedation coordinated in our younger kiddos. I know is that's hard on the inpatient side, so I really cannot imagine how much longer it must take. And I think that's really the big fear, right? Is especially we all want that gold standard MRI, but it's ultimately not as easy to get done in Hawaii as we would like, even if you live on Oahu. Okay, more questions coming in. You can see it as well.
So. Yeah, so how are low-dose CTs in detecting brain malignancy? If there's you know, if there is so oftentimes when you do STAT CT, you're going to do it like if you're looking for a bleed, right, would be one thing, and you're going to do non-contrast. So sometimes the non-contrast might not show, but if you have one with contrast, then it should be able to pick it up, or even if there's mass effect of some sort, most of the time you're going to see some type of abnormality. Could it miss it? I believe it could. I don't want to misspeak, but I think in general, if there is some abnormality, that it should be seen, and it should be seen. It should be seen. Yeah, it's not an absolute, right? So like nothing is 100%, but it should be able to see at least that there's something not normal.
Yeah. And I think stat CT is usually ultimately what our ER does as well, just to kind of get imaging quickly, because they're equally not necessarily always able to get that sedated MRI,
Right.
as quickly as we would want.
Yeah.
Thank you for answering all of our questions. I'll kind of slowly start winding down and see if anything else pops up. Otherwise, everyone gets an extra 5 minutes of their lunch break, which is not the worst thing by any means. So thank you so much again for joining.
Thank you. Thank you all for joining, and thanks for having me today.
Thank you for coming into the chat. Yeah, this was always a really good refresher, and it's such a scary topic, I think, for ultimately all of us, that it's great to know that we have you,
You're sweet.
and your expertise. Next week we are going to be talking about not next week, I'm so sorry. Our next session is going to be Dr. Andras Bratensak. He's going to be talking about chest pain and syncope. And I know that's a topic that I personally, oh my gosh, anytime I get those kiddos, it's not the most fun workup, and you do a lot of weeding through ultimately. Yes, very reassuring patients at the end of the day. So that'll be a good one, I think, for our outpatient folks as well. So thank you, everyone. Have a great rest of your Wednesday, and we will see you all next time.
Thank you. Thanks again for doing this. And again, feel free to reach out or email or contact me if you guys have any other questions about other ones. And thank you.
We super appreciate that. Thank you. Thank you. Thank you.
Thank